we've pictured the various instrumentation that's needed for the basic humeral preparation. On the right side of the screen, we see the apex instruments that are needed. On the left hand, we are calling out the Univers II instruments that are needed for humeral preparation. So the first step that we would utilize is the intermedullary reamer. There's a couple things that we want to point out. This is again the apex intermedullary reamer, and you can see there's a scalloped line right here, which is a depth indicator. This is typically the depth that you would use as a barometer for when the head has already been resected. This flare on the reamer's shaft would be the depth that you would have if the head had not yet been resected. Okay. The connection point to the T-handle is the exact same across both, and really the only principal difference between the intermedullary reamers between the apex and the Univers II is the depth of the flutes. The next thing we'll be covering is the broach, which shapes the canal for the implant. It's important to note that the broach fit will be undersized by 1.5 millimeters. So in other words, the definitive implant is going to have a 1.5 millimeter press fit, so it's going to be much tighter than the broach feel. The differences of the broach are obviously the broach length. There's a couple other things that I like to point out. The first is that on the apex broach handle, you have these two threaded holes that will accept the version rods. So those are oriented again at 20 and 40 degrees. So aiming between the 20 and 40 degrees gives you that 30 degree of optimal retroversion that you're aiming for. The other is that obviously the length of the broach is different, and there is a broach alignment slide that's cut out here. There's a broach alignment for the apex which has these nubs on them, which serves to capture the slide so that in a case it doesn't allow for the slide to fall off the broach. Okay. That differs from the Univers II broach handle, which has an open-ended slide which allows for the broach alignment guide to simply slide off in the middle of the case. So if you're doing a Univers II, be very aware that the back table should be passing this with their hand on the broach alignment guide so that it doesn't fall on the floor. The other difference of the broach between the Univers II and the apex is that you'll notice there's a lateral fin that is cut on the broach for the Univers II that's obviously absent in the apex. Taking a tighter shot of the actual face of the broach, you'll see there are different laser etches that are included that correspond to the various inclination angles. This is not intended to be a specific measurement of the inclination, but rather a guide to assess your broach depth. You'll see that there's a dimple on the lateral corner, lateral superior corner, and that's a barometer of how far you should be broaching. There are some variability in that, but it should be a guide for sort of your minimal depth of the broach. One additional difference on the Univers II broach handle, unlike the apex, is that there's no threaded holes for version rods. So we have this ancillary guide here, oftentimes called a clothespin guide, and it may be used in left or right orientations to simply squeeze and clip into the superior lateral hole of the broach, like so. The sequence of steps for humeral preparation are identical between the Univers II and the Univers apex. For the purposes of this demonstration, we're just going to go over the sequence for the apex. So you'd start by obviously making the head resection. After the head has been resected, oftentimes people will open up the canal with an additional pass of the IM reamer. Okay, where that scalloped line is, that's the depth at which you want to stop. Okay, and once that has occurred, you are then moving on to broaching. It's important not to over-ream the canal. Some competitive systems require the users to ream up to cortical chatter in the intermedullary canal. It's not advisable to do that in this particular system, and instead let the broach do all the work. So we're going to have inserted the broach alignment guide onto the channels of the broach, and we're now going to sequentially broach the proximal humerus like so. The The one thing that we're looking for as we're broaching the humerus is to make sure that the dimple on the lateral side of the broach handle is at least to the resection depth. You can barely see it right now in the video, but you can see that that depth is about perfect. As I insert the broach into the canal, it's very important to make sure that the version alignment guide has both the anterior and posterior feet resting firmly on the resection plane. That makes certain that your orientation or your rotation of the broach is aligned with the humeral resection and aligns the retroversion of the broach. So I'm going to hold this here just with one hand, and now I'm going to then gently mount this down. I've mounted it down to the point where you can hopefully see that the dimple on the lateral side, or the proximal lateral side of the broach handle, is now buried slightly below the resection plane, which gives you the proper depth at which to stop. I'm going to then make sure that there's rotational stability in this implant. Oftentimes surgeons will toggle this back and forth. Again, it's really important for them to assess the fit of the broach and realize that there's an additional 1.5 millimeters of press fit on the definitive implant. So if it's tight with the broach, it will be even tighter with a definitive implant. Okay, so once that has been broached and I'm satisfied with the fit, I'm going to remove the broach, and then I can go on to implant the definitive stem if I so chose, or if I wanted to trial, I could utilize one of the protector posts from the apex and insert a size of the last used broach on the protector post. The protector post, or the humeral trials, exist in both the Univers II as well as in the apex, and they're seldom used. However, for those who wish to prepare the humerus fully and move on to the glenoid after, there's ways in which you can do that. One is by inserting the protector post to the resection protector, like so, and using this lateral set screw to capture this resection protector. Alternatively, if somebody actually wants to trial and use a trial trunnion, they may insert the trial trunnion in the same manner, like so, taking the hex screwdriver and capturing that set screw. That still allows for the degrees of float allowed by the humeral prosthesis, definitive prosthesis, but allows one to trial off that protector post as an option. Okay, the canal has been broached. So at this point, we're ready to introduce the definitive implant. So one thing that the back table should always check is to make sure that the inclination block is fully floating, as well as the version itself, right? So these are both loose when you're putting it in. Obviously, this is the apex, and it has all of the different suture eyelets. If we were doing the subscap repair technique, that is one of the hallmarks of this particular implant, we will have, of course, loaded each of these suture eyelets with the proper fiber wire for that particular repair. I also want to give you a little bit of a closer shot of this little lateral dimple right there. That lateral dimple is oftentimes used along with the pencil-tipped impactor to initially impact this implant into the canal, and I'll show that just in a second. So first we're going to do is place this implant into the canal with thumb pressure. We would then take the pencil tip impactor, like so, and place it on that lateral dimple. And this is sawbones that's already been pre-prepared, so it's not giving us the point as well. But this would be impacted down to the point where the pencil tip impactor is starting to get very close to the lateral aspect of the resection plane. At that point, we would then introduce the trunnion impactor. And this is aligned with the axis of the humerus. So the shaft of this impactor should be in axis with the humerus. Oftentimes people want to do this way or this way. It just doesn't work that way. So it should be aligned with the humeral axis, like so. And that would be then impacted with the mallet until the collar is flush and seated fully on the resection plane. At that point, we can provisionally tighten the inclination screw, which is the inferior screw right here with our hex driver, like so. We can make sure that there's no soft tissue occluding or inhibiting the seating of that hex driver, so we'll do a thumb tight down there. If there is soft tissue sometimes or bone that gets trapped in that hole, suction or a freer elevator often will help get that bone out. We then go to the trunnion screw like so and provisionally tighten that, and that again will control the retroversion of the implant or anteversion of the implant. So that after those have been provisionally tightened, we can then take our torque indicating driver, which is a hex driver, and then we'll again start with the inferior screw and we'll rotate this until this laser line right here is aligned to either the inferior or superior laser lines on the guide. I'm going to start to do this, and I don't know if we'll be able to see this on camera. Okay, so we'll do that until the inferior aligns with this laser etch. We'll do the same process on the superior screw. So we're going to make sure that the laser line for the superior hole aligns to the singular laser etch mark, like so. That means that you've torqued this to the appropriate amount. You'll have done the same on the inferior line as well. So hopefully the back table will have taken the resected humeral head and pre-sized it by placing the resected humeral head on top of the trial in a clamshell fashion. They'll find the appropriate size and then simply introduce that onto the trunnion of the definitive implant. You'll notice there's a line that's inscribed on the surface of the trial, and that indicates your position of maximum offset. So each of our trial heads has 3.5 millimeters of offset or eccentricity, and that indicates where that max point is. We have a head driver that corresponds with this slot on the apex of the humeral head, and that driver allows you to rotate freely the eccentricity of the head. Obviously with bloody gloves, it sometimes is slippery and one's not able to do this, but this driver does a nice job of being able to orient the head accordingly. At this point, they're going to reduce the humeral head and assess for range of motion and do the shuck test and soft tissue tensioning. If that's the size they end up going with, they'd simply open the definitive humeral head, take this trial head off, and impact the humeral head in the same orientation with the humeral head impactor. Okay, we're at the point where we've reduced the trial head in the joint and know that this is the size that we're going to choose for the definitive head. So to remove it, typically people will just simply remove it with their hand. If their hand is slippery, they can also use the head extractor device to create a wedge underneath the underside of the provisional head and simply remove it. It's important to notice the position of maximum offset that was utilized on the trial head, because that wants to be replicated on the definitive head. So we've had a definitive head of the same size, and I've turned it upside down so you can see some of the features that are included in that. Obviously you can see the undercut area, which is where the trunnion rests. That allows for a nice radiographic image where there's not a gapping between the trunnion plate and the underside of the humeral head. Secondarily, there's these 4 undercut channels that allow for you to do 2 things. One, during a revision, you can extract by placing the chisel or that head extraction tool in that channel and wedge that humeral head off. Additionally, one may choose to use this same tool and orient the offset of the humeral head to get it into the position that best fits the patient. And I'll show that in just a second. There is a laser etch as well as a dimple on the position of maximum offset on the definitive head. It's on the underside of this, obviously, because we can't laser etch the articular surface of this particular humeral head. So a lot of times people will take a skin marker and take that laser etch and carry it forward onto the articular surface so that they know the position of max offset. So assuming that's all been done, we're going to then place by hand the definitive component on the humeral trunnion, and then we'll take the inserter impactor for the humeral head, place it on there with a couple of sharp mallet blows, impact onto the surface, and then the humeral component is complete.